Hello everyone and welcome to the webinar. I'm Vasant Rao, founder trustee of Dr. Shyama Narang Foundation, which runs the MND Trust. The foundation is a registered, not-for-profit organization formed to search a cure for MND through coordinated efforts and until such time to be a support to people with MND. Today, it's my proud privilege to welcome the chairperson, Dr. Gauri Devi, all speakers, panelists, moderator, and all you participants to this global webinar. The tone of this webinar will be set by Dr. Shyama Narang Rao, Registrar of NIMHANS, a world-renowned Center for Mental Health and Neurosciences set up by Government of India in Bangalore. Before I hand over to Dr. Shyama Narang Rao, I would like to make a brief introduction of Dr. Shyama Narang Rao to this august audience. Dr. Shyama Narang Rao is a neurophysiologist at NIMHANS and also its registrar. He has a wide area of research in the field of neurology, and many of his researchers, especially in the area of cellular and molecular mechanism, has led to advanced drug trials in mental retardation and autism. He has over 150 publications in high-impact journals and over 12,000 citations. If you Google, there is copious information about him and his research. Dr. Rao, it's indeed an honor for Dr. Shyama Narang Foundation to be associated with you personally and in official capacity with NIMHANS. I warmly welcome you, sir, to set the tone of the webinar and to introduce Dr. Gauri Devi to this august audience. Thank you very much, sir, and a warm welcome to everyone to this webinar. Before I hand over the screen to Dr. Shyama Narang Rao, a few housekeeping points for all the audience and participants. Please type your questions in the Q&A box and we will read it out. We'll read them out to the speakers and panelists. Recording will be made available to all who have registered and also posted online in IndoUSrare YouTube channel. For those who may leave in between, we will make the recording available to them. Thank you. Over to you, Dr. Shyama Narang Rao. The screen is yours now.
So good evening and thank you very much, Dr. Vasant Rao, and also all the panelists and the distinguished speakers. I cordially welcome for the best practices for patient registries in Indian context. So today we have a special focus on ALS and MND. And so before we set the ball rolling in the panel discussion, we have extremely, well-recognized and world-renowned neurologist, Professor M. Gauri Devi. She is our teacher, and her contributions related to the ALS and MND is very pioneering. In fact, her neurological contribution of various brain disorders, including MND, which spans for almost like 5 decades of her service to our country. And she has over 200 publications, and each one of them are the reference point for any neurologist and also for the basic scientists. What is most important is that Professor Gauri Devi, as a neurologist of world-renowned and eminence, in addition to that, she had wonderful the clinical research as well. So in fact, her contributions for the ALS research, in India and also internationally is well recognized. So using the CSF sample from the ALS patients, so she helped our entire team of NIMHANS to characterize the factors or the toxic factors which are responsible for neurodegeneration of the specific neurons. They are the motor neuron diseases. So that way, so as a neurologist, as a clinician, and more importantly, during a regime as a director of NIMHANS, so many firsts has been witnessed by us. And she put a lot of foundation stone for the further growth of NIMHANS. So considering her expertise in neurology and specifically into motor neuron disease. So it is very apt to have her as a keynote, presenter. And it's indeed a great pleasure to introduce our teacher, Professor M. Gauri Devi. She is a emeritus professor and at the HIBAS, and she has several innumerable awards she has received as a neurologist, as a clinician, as a researcher, and each one of them culminated into the expertise which she has possessed in terms of the motor neuron disease specifically. And on behalf of each one of you, it's a great pleasure to welcome Professor M. Gauri Devi to deliver the keynote address. Over to you, madam.
Thank you very much for the very kind introduction. I think it's a great initiative which has been, thought of well to make a MND Trust in India and to collaborate with organization in US and of course NIMHANS. I think it's a great advancement in the country from the patient's point of view and the caregivers and the neurologists. I would like to speak something on the registries, the need for a registry for motor neuron disease. Let me share my screen. So just to introduce ALS, which we are all concerned with, it's unfortunately a progressive degenerative, neurodegenerative disorder of the motor neurons in the cerebral cortex, brainstem, spinal cord, and they have various neurological signs. It's important to recognize that 5 to 10% of familial in the global index, but in India, we find it is perhaps less than 3% or 5%. In our studies, it has been 1 to 3%. The sad thing about this is that 50% of the patients survive for about 3 years or so, another 30% for 5 years, and a few lucky people group survive for 10 years or even more. There are drugs available to prolong the survival, but as yet, no definitive treatment has emerged for either curing or reversing the process. So this is for people, maybe not neurologists, but others, to know how widespread these degenerations can be from the cortex, along the pathways in the brainstem, in the spinal cord, giving rise to various symptoms of difficulty in speaking, swallowing, weakness, wasting, etc. And there are multiple mechanisms of this neurodegeneration, the excitotoxicity with glutamate, oxidative stress, then mitochondrial dysfunction, and so on. And neuroinflammation is the current hypothesis also. Therefore, when we are thinking of drugs or agents, we have to address all these issues. The prevalence worldwide in the recently quoted paper varies from 4.1 to 8.4 per 100,000 people. Annual incidence is 0.6 to 3.8. We have only one study, that is ours, a community survey to look at the epidemiology. And this was done in the state of Karnataka, Gauribidnur, and we found it was 4 per 100,000. It is in consonance with the global data. What is worrying is it's projected that ALS cases are going to globally increase by about 50 to 60% due to aging of the population. This will happen also in the developing countries as well as developed. In the Western studies, the mean age at onset, this is from the published reports, is in the 6th or 7th decade, and male, female is 2:1. From data from the Indian studies indicate that 1 decade earlier, we seem to develop the illness. And in 30 to 50% of ALS patients in large series from NIMHANS with Dr. Nalini and I, we put down together, age of onset was below 40 years. There seems to be more males than females, but it may be an artifact because women may not easily come to hospitals for consultation and diagnosis. So what are the problems here? Unlike many other illnesses, there's no biological marker. We can estimate something in the blood or any other parameter, and there's no definitive diagnostic test. All that depends is on a good clinical neurological examination, including history, taking the whole thing together takes quite some time, sometimes half an hour to 45 minutes or more, and then confirming by electrophysiology that where is the damage and how severe and so on. An important thing is to exclude treatable disorders which may mimic MND or ALS. That's very important because even 1 in 10,000 you find a mimic and that gets treated and the diagnosis is changed from ALS to some other disease. I think it's a great thing. Now, it's important to recognize that motor neuron diseases can show as ALS or primary lateral sclerosis. Why I'm mentioning all this is that in the registry, all these have to be captured. And then even ALS can have different phenotypes. Somebody coming with difficulty in swallowing and speaking, others coming with classical type with involvement of the upper and lower limbs, flail arm syndrome where there is a proximal weakness. I'll just show a few pictures of it. Similarly for the leg, some people may have more of stiffness and others may come to the hospital in an emergency situation with a respiratory problem. So like this patient came with a difficulty in swallowing, the tongue wasted. Another patient came with wasting of the muscles. And here is the flail arm syndrome where the distally the muscles are normal, but proximally it's wasted. And here is an example of a person who has a severe wasting, but most important is the head drop, and he has to support with the hand. These all become important when you're looking at supporting devices, technological involvement to improve this mobility and also the supporting the neck. So how do we go about registries? There are rare diseases and ALS is considered a rare disease. Published reports of rare diseases usually are limited, which focus on the natural history, clinical details, and outcome of treatment. The involvement of various stakeholders, which we will be addressing now, as there is a need for knowledge and expertise to manage these diseases. Obviously, you need infrastructure and research to better understand the epidemiology and natural history. And while we are thinking about that, simultaneously rapid advancements in technology and research in genetic and molecular levels are evolving very rapidly. To translate these advances to clinical research is quite difficult. Lack of monetary support from governmental and non-governmental organizations is very obvious, at least in India, so similarly maybe in other countries. Therefore, creation of a registry for rare diseases, we can capture the clinical, genetic, and biological data very systematically. They also form a comprehensive base for information and understanding the disease. This is for all rare diseases. Now we come to ALS and MND. What are the objectives of our registry? I think that is the main focus of today's webinar. One thing is to connect affected patients, families, and clinicians. to learn the natural history, the evolution of the disease process, risks and outcome. To support research on genetic, molecular, and physiological basis. Important to establish a patient data for evaluating drugs, medical devices, and orphan products. And of course, a lot of emphasis on clinical trials. It is seen that population studies have revealed that ALS frequency is different in different continents and ethnicities. You have high endemic foci and some countries with a very low prevalence of ALS. Now, where do we stand? A national registry in India will provide data on prevalence and incidence. And we don't know whether it's all going to be homogeneous across the country or in different regions, it will be different prevalence and incidence. And other thing is, locally, you may find some interesting or unusual types of presentation or a disease pattern, which is worth considering. You know, when you look at the whole data, maybe majority fall into the classical descriptions of ALS, but some may be different. And it will also enable us comparison with global data. The demographic and clinical data in an organized way has to be done using standardized methods. So each country and for a disease process, keeping in view the age groups, the socioeconomic status, and how various levels of the country, like urban cities, metros, and second level, third level, and so on. Effective monitoring of temporal and geographic trends in the distribution of the disease. And one is always concerned about the environmental risk factors. It will be possible, are the same risk factors operating across the country in different regions? Firstly, we have to identify the factors. And this captured data not only leads to research, but also improvement in clinical care. And obviously, you need health policies and allocation of resources more efficiently, maybe governmental or even non-governmental. Now, when we say a public health issue, you know, a rare disease obviously will not attract the public health domain, but it is for us to make it important and show to the government and other organizations who make policies that you need to help such people with various problems, day-to-day living, disability, and so on. Accurate data is also required for surveillance and monitoring, as well as individual care of the patient. And in registry, the data sharing must be made simple. If it is very complicated, people find it difficult to be a part of the registry. Obviously, a lot of effort is required to maintain a registry. And very significant is the security. It's a challenge. Authentication process, users with various variable access levels, who can access what data has to be defined, and data encryption and patient data anonymization, because names and other things should be anonymized. Focus on the clinical trials I've already mentioned. Now, the stakeholders in any registry are firstly the patients, families, caregivers, they are the participants, patient advocacy groups, and clinical investigators, that is the neurologists, so on, data contributors, academic will be research, investigation, so on, and biopharmaceutical industries may sponsor, may develop drug development, etc. Government and regulatory agencies, sponsors and recipients of information. So all these stakeholders should work in unison with complete transparency between the groups, and so that everybody understands what the other groups are doing. So there are national ethical guidelines for biomedical health research from ICMR. I have not put everything here. I think you can get it on the website, But most important, which I found is, if multiple institutions are taking part in gathering this information, entering the data, ethical clearance have to be obtained from each of these institutions. Data confidentiality has to be maintained, it has to be reiterated. The electronic record should not have any patient identifiers. Patient consent is required. Therefore, one information sheet and consent form that should be there in the local language. There are issues of reimbursing the patients, particularly for research issues. So there are many more in regard to these paying the compensation, etc., which is found on the ICMR website. Now, what are the challenges as I find? How do we identify the affected people? That is, we cannot look at the community at large and say these are the people who are affected. So obviously, these patients will come from neurologists, maybe physicians, who identify the disease and develop a protocol. My concern is who will enter the data? Will institutions, tertiary centers be identified, and the neurologists there will enter the data? Or do we have, there are individual neurologists practicing in small places, but very good. They also see ALS patients. Will they be linked up to a tertiary center? What happens to that group of people? Can the patient enter the data as it's done in other countries, or the caregiver? I'm not too sure about the Indian context, whether the patient will be able to enter. What database is required? That has to be developed, including all information about the subject, the demographic data, the symptoms, evolution of the disease. And we are also thinking ALS, beyond ALS, some overlap syndromes, odd patients, different disorders. So a very detailed database has to be developed, whatever information is needed. And verification of accuracy of data. How is it going to be done? I mean, I know there are IT people in this group, so they will be able to tell us how to do it. Data confidentiality and privacy of the patients, we have already discussed. Ownership of the data. Who owns the data? And what are the roles and responsibilities of various stakeholders? What approvals need to be taken, apart from the ethics, any other approval? And who can publish and disseminate the data registry? Finally, of course, you need funding, maybe quite a large amount of funding, and over a long period of time. It cannot stop in between. So this is what I would like to say, that registry for ALS MND is high time we did it. We had been thinking about it, but then it really didn't materialize. Thanks to the MND Trust, which has been formed, I think I'm seeing the light at the end of the tunnel. Thank you very much.
Thank you very much, madam. And so all the points which you have raised, they are very pertinent and they are extremely important when we enter into the registry. And most importantly, the various challenges and also having a proper maintenance of the data and the ownership and publishing and the ethical components associated with evolving the registry. So each one of those points which you have mentioned, they are extremely important. I am very sure that during the panel discussion and the inputs what we are going to receive from the panelists, and each one of them can be put together and it should culminate into some kind of a document which is going to be helpful for each one of us, not only to the MND registry, even for venturing into any kind of a registries. So on behalf of all the participants, I take this opportunity to thank you, madam, And if any questions are there, and so during the panel discussion and also subsequently, we will be in touch with you, madam.
Thank you, Shankar. Thank you.
I invite Dr. Harsha to take over and introduce Dr. Swasti Charan.
Thank you, Nara, and thank you, Dr. P.S.S. Rao, and for a wonderful keynote presentation by Dr. Gauri Devi. It's my pleasure to invite Dr. L. Swasti Charan, who is the Additional Deputy Director General and Director of Emergency Medical Relief with the Ministry of Health and Family Welfare, Government of India. Dr. Swasti Charan's major areas of work have been in emergency medical relief, rare diseases, pre-hospital care, and he's been a World Health Organization Fellow in Health Impact Assessment at the Liverpool University in the UK. And he was primarily trained on disaster preparedness and response at the Asia Disaster Preparedness Center in Bangkok. So it's a pleasure that he is now leading the effort for rare disease patients in India, which has been a disaster for many decades. And with Dr. L. Swasti Charan's leadership at the government, we have a lot of hope. And we now have a national policy and his guidance on how we can work effectively with the legislators and policymakers and how we can all collaborate more effectively. So thank you so much for making this a priority today, Dr. L. Swasti Charan. I invite you to make your remarks on this occasion of MND Day. Welcome.
Thank you, Harsha. Thank you for the kind words, and I would also like to wish a good evening this evening here in India to all the esteemed panelists who are eminent neurologists and other faculty members of medical colleges, as well as colleagues who have been working for the cause of rare diseases in this country. I must admit that I'm not that young anymore for rare diseases, but I'm not too old for the rare diseases. We took up the whole team of rare diseases who are present here today, took up the agenda of rare diseases about June last year. And as Harsha was saying, we realized that we had a lot of things to do for rare diseases in the country. A lot of effort had been made in the country, and in the past, when we looked into it, we were already having a policy of the national rare disease policy of 2021, and it was released on March 2021, and then we were trying to implement it about June 2021. I'm not saying that before the policy there were no efforts being made for rare diseases. There were, but it was all scattered, and the rare disease policy, brought back many spectrum of rare disease in the country. I look after many national programs in the ministry. Some of them are National Tobacco Control Program, National Oral Health Program, and also had the emergency medical relief, and deals with what is known as public health emergencies of international concern, etc. So whenever we try to do something for that, for a disease or a condition, the first thing we look at is what is the burden of that condition. Say if it is mental illness, we try to find out what is the mental illness burden in the country, and we do have a survey being conducted by some organizations or some agencies in the country, like for example, for the Global Adult Tobacco Survey, we have TISS or All India or the IIPS Mumbai trying to do the series of Global Adult Tobacco Survey, etc. So for rare disease, when I started looking into it, then it was some quoted figures from various international journals that we see that about 7,000 to 8,000 of them are rare diseases, and because of the nature, it was not possible to do a disease burden survey. Then I was thinking, then in what way are we going to estimate the actual burden? So that kind of a question in my mind led to search for a registry. Like I know, I'm aware of the cancer registry, what we have in the population-based cancer registry, as well as hospital-based cancer registry, and we do have something for the registry even before the NCT survey that we did for the country. So that led me to the portal of the ICMR, where we had the ICMR cancer registry for the rare diseases. And then we tried to put many pieces of the jigsaw puzzle, trying to solve the acute cases for rare diseases which were referred to us. Those were many of the letters were written by the BVIPs and the VIPs to our health minister, asking for help, asking for assistance for many of the patients suffering from various rare diseases. Some of them were not rare diseases as per the policy, but we do have a provision under the policy that if a disease is brought to your knowledge and you know that it could be a rare disease, we have a committee under DGHS, which is known as National Committee for the Rare Diseases, Central Technical Committee for the Rare Diseases, and then that committee can decide on case-to-case basis whether that particular disease is a rare disease or not. And we have done that for many of the diseases, and then it doesn't end in just trying to decide whether it's a rare disease. We also decide to classify them into group 1, group 2, and group 3. So till recently, as per the policy, we had the provision about 20 lakhs Indian rupees, which was limited, which was to be facilitated through the Rashtriya Arogya Nidhi, and it was only limited to group 1 disease. And then we had in the policy of creating a portal and then waiting for the donations to happen for the group 3 patients, which for the support for the group 3 patients. And we realized that the portal has been up there from August 2021, and we have registered say about 300 patients, and the requirements would be ranging from about 125 crores or so, and the amount of donations that we have as of now range only to about 1,25,000 only. So it's a huge gap. So, and we cannot push people to donation further. And we have the Rashtriya Arogya Nidhi fund, and that to a ceiling about 20 lakh rupees, only catering to the group 1. So the group 2, we think and we expect that the state governments would be helping the group 2 patients, but the patient advocacy groups and many groups come and tell us that even many of the state governments are not aware, even the patients are not aware that they are suffering from group 2 and they could approach the state government. So these were some of the challenges, and we did a lot of advocacy here ourselves, and we also had many advocacy groups working and pushing the agenda of rare diseases. And very luckily, we have got great leadership and a political will, as well as the administrative will in the ministry suddenly. And our additional secretary and mission director, Madam Roli Singh, she directed that we should increase the ceiling to from 20 lakhs to 50 lakhs, and it should be we have now expanded it not just group 1 diseases but to all the groups. That means group 1, group 2, and group 3. Whoever is considered as a rare disease, and whichever rare disease they are suffering from, they can avail a one-time support from the ministry up to 50 lakh rupees. And friends, I must tell you that in the last 3-4 weeks, although we have made the announcement, although we have released this information to the public, to administer this particular fund, it's not that easy, because the rare disease, many of you are clinicians, you know better that they come in different shapes and sizes, and some will get a treatment one time and they can get well. Some will get treatment as a package every 6 months, and it will continue for about 2 years. And then that should be considered as a package, or one episode of, giving an ERT should be considered a one-time package for that particular patient. And if I limit to that, then it's of no use when you require it for 2 years, or when you require it for many years, when you require it for lifelong. If I say that it's a one-time payment of 50 lakh for this particular disease, it may not, it may not serve any purpose for that the particular patient. So it has been a dilemma, but we also have another very cooperative officer in the form of Mr. Ravindra Prasad, the director who looks after this. He deals with I deal with the technical part, and he deals with the financial and the funding part. And both of us have been trying to figure out and frame a proper guidelines so that we cater to as many patients as possible under this fund. It's not easy, and we have been trying to finalize it this week and tomorrow morning. We are also trying to, finally decide on some guideline and then give the funding to the Center of Excellence that we have established in the country in 8 centers of excellence. Now the funds will be going to the Center of Excellences, and the Center of Excellence number we need to increase for this country, because 8 is not enough, and everybody trying to get into the 8 centers, it's going to overwhelm. And so the government has made efforts for increasing the number of Center of Excellences. The first being the AIMS Jodhpur, who has submitted a proposal, and a central team has visited, and they had examined and they have come back with a positive note, and the CTCRD has already approved that we can consider AIMS Jodhpur as an additional 9 Center of Excellence. We also have received the request for 3 Center of Excellence from the single state of Kerala, and the central team has been formed, and my colleague Dr. Charan is going to lead the team there to examine the centers, whether they can be recognized as centers of excellence. So we will decide on how many of them from Kerala based on their report. And we are also getting proposals from Tamil Nadu. We are also getting proposals from central government institutes like JIPMER in Puducherry, and we are also exploring how we can do it in the northeastern part of the country. Now, having said all this, my biggest interest lies on tracking the rare diseases, which is going to come to the centers of excellences, and also link with some kind of information that we have in the portal. We all know that was established for catering to the group 3, and it will be those patients who have come to the centers of excellence, the 8 centers of excellence, and then whom the experts in the centers of excellence have examined and found them suitable for support, and their names only come into the portal. But in all fairness, the people who are there in the portal should have been a subset of the original, the overall registry that we are maintaining from the ICMR. So we wanted to see whether there's a syncing here. And so we had a meeting only last week, with the ICMR people, and we tried to understand how the registry is being maintained. We also realized that apart from the diseases which is listed in the national, rare disease policy, there were also other diseases which were there in the rare disease policy, and we have all decided that there's a need to sync our efforts together. And friends, the fight against the rare diseases is not very simple. It has to be multi-pronged, and it has to be evidence-driven, and the timeliness of diagnosis, timeliness of getting the right people to the right center, and also trying to find the right treatment, and also giving them adequate or the optimum support from the ministry, not just from the central government, but also from the state government. We all have to, these are the jigsaw puzzles that we need to put together. So, and we also need to sync with the efforts of the DCGI for the various drugs that are available and not available in the country, and how they can be facilitated. We have to be honest with the drugs which are available outside, whether they need to be permitted in the country, or whether there's a need for doing our own research and trying to find our own drugs for many of the conditions, like the way we did for the COVID vaccine in this country. If we could do for COVID vaccine in record time, why not for the rare diseases? So these are some of the unfinished agenda which we are flagging at every point in in many of our meetings here. We are also trying to find out who could be the potential donors, who for some reason, maybe they are not able to donate in the portal, but they could be donating directly to Center of Excellences. And then if you go to the Center of Excellence, we find that there are very busy clinicians who are treating patients and who has no expertise or no time, in a way, no time to, to write a proposal for donation from the COEs. We are also trying to facilitate them with a small unit being provided by the ministry or any of the donors to the COEs, so that, we facilitate the flow. So we have identified, we have done a resource mapping. We have also identified many of the challenges. We are also trying to find many of the solutions for management of rare disease in the country. The political will as well as administrative will is there, but by the mere fact and by the nature of the rare diseases coming in different shapes and sizes, we do not have one solution fits all for the rare diseases. But we should be catering to as many as possible. I know that with the efforts that we are doing here, we may miss out many of the patients who require maximum, support in the, say, for example, I'll take the name of spinal muscular atrophy. Our 50 lakhs will not be able to cater to that, and the spinal muscular atrophy, diagnosing them in the entire country by means of a screening, building the capacities of the ASHAs and the ANMs, so that they are brought into the right health facility before 6 months, and trying to give them an affordable ERT will remain a challenge. But SMA is not the representative of the entire rare diseases. So we should not stop our efforts for the want of the best solution for all. So that, with that motto, we are trying to maximize our effort, and we are not leaving SMA behind. We are negotiating. The minister himself is negotiating for the price of the drugs. And we are also trying to drive through various potential donors who could be, donating to the COEs for funding as much as possible for the rare diseases. So, as I always say in many of these webinars in the past which I attended, I do not like to say that it's an orphan disease that we are dealing with. We have owned them as our own, and it is our collective responsibility to cater to the rare diseases of this country, patients suffering from rare diseases of this country. We may not be able to give them to some of them who have crossed the timeline for providing, say, ERT or so on. We may not be able to give them the definitive treatment or turn back their lives, but we will do for the future generations of the possible rare diseases by trying to prevent them. If we are not able to prevent them, detecting them as early as possible and giving them the optimum care. Then if we missed out in all this also, many of the rare disease patients who are suffering, we should be able to add some quality to the remaining years. And that can be through the supportive treatment. So we will work with the COEs in such a way to find out a spectrum of services that we can provide to them, be it definitive treatment, be it supportive treatment, but we should be doing them. We should not leave anybody behind. So with this motto, we are working in the ministry, and I'm glad to say that earlier one of us attend these webinars, but today my entire team is also attending this webinar. So that shows the commitment from the ministry, and we continue to be guided from many of the well-wishers, including the academicians of this country, like Professor Gauri Devi ma'am, and we will go with your guidance and your blessings, and we all will try to do something for these unfortunate patients who have been suffering for long. With these words, I thank you for inviting. Thank you very much.
Thank you so much, Dr. Swasti Charan, for those wonderful remarks and some very encouraging news for patients with rare diseases coming from the government in the recent weeks. So very, very encouraged. From no funding to 50 lakh rupees of funding per patient, one-time support is commendable and very welcome. There are a lot of questions popping in from the audiences, and a lot of this information is still relatively new. And we are at IndoUSrare also disseminating this information to all the patients who contact us and in our network. So more and more patients can avail this government support. Thank you so much for your leadership. One quick question, is this 50 lakh support meant for one time? Can that be used for a lifetime supply of nutritional supplements and medications, or does it have to be spent for a gene therapy or one time?
Yeah, that's what I was saying. We'll have to see as a package, like for say one-time payment, and we do a gene therapy, or say we do a liver transplant, or we do a splenectomy, etc. So many of them could be done there, but there would be challenges like those people whom we are. So we are trying to finalize that, and we might say that if someone has taken if we see that, I don't know all the rare diseases, I'm not a pure clinician. This is a very, I must say, very deep science involved in that. But say, for example, if we need to treat somebody for about 1 year, and we have taken at some point, and then after 6 months, that person has taken, after taking 20 lakhs, 30 lakh is still remaining there. So that patients can, avail that 30 lakhs again within it. So we have to decide the duration. We have to decide whether 50 lakhs will be, earmarked for one particular patient, or whether the fund will be rolling. So that, I can't say, suppose if I have some money, then if I allot it to one patient, and then I don't get enough fund from the ministry for some reason, and a needy patient comes that, with 20 lakhs of rupees, he, with one-time treatment, say, for example, bone marrow transplant, he is going to survive. But I had allotted that fund to somebody for whose supplement will continue for 1 year, then I may have to decide that for now we will use it for this kind of stuff. So the financial, regulations from our side, and the clinical wisdom of the COEs, as well as the directions given from time to time by the Central Technical Committee headed by the DGHS, will have to come into play. So we are really working on that, and tomorrow morning we have a meeting trying to decide this. But let us roll it out, then learn on the way, and then try to improve the guidelines so that we cater to as much as possible. The intent should be clear. Intent should be, the intent inside should be all inclusive. It should not be exclusive. That's what we think as of now.
Great. Thank you so much again, Dr. Swasticharan. Appreciate your support and leadership. So let's move on with the program. Dr. Gauri Devi, there are several questions. I'll just ask one question from the audience to you, a burning question from a patient asking, what's the best nutritional supplement or any supplement that you recommend for patients to extend their lifespan with MND or ALS?
There are a number of supplements which are helpful, high protein, high caloric diet, because the patients lose a lot of weight because of the muscle wasting. There is no special preference. I know people say so-and-so took this from US, it's very helpful, it is prolonging survival. I mean, one cannot really justify those. But generally we mention, take care of the diet, make sure that enough of protein diet is taken, particularly those people who cannot swallow, eat solids, we need supplements for that. I don't think we recommend a particular supplement. It is overall, I think, most important. At one stage, they said drinking coconut oil will help. One or two patients mentioned that. So everybody wanted, they used to come to me and say, Madam, should we use coconut oil in our food? So there are many things which have come and go, So I wouldn't say a particular supplement. Good nutritional diet, taking care of various aspects, vitamins, protein, calories, etc.
Yeah, and one other comment has been made that the prevalence and incidence is highly undercounted in India, as most patients may be actually dying very quickly and may not be surviving, or they may be undiagnosed. Would you agree to that statement?
It's true. If you look at people who are in remote areas, we would never know what they died of.
Yeah.
As the health services expand and go more interior, patients may be referred to bigger centers. It is true. that prevalence and incidence will be always underreported in countries like ours. But compared to earlier years, now I find more and more physicians are referring to neurologists, and neurologists are able to make the diagnosis and offer advice. So there is a changing picture. Okay, but it's still for a country with such a huge population. I'm sure many are hidden. Even in the cities, they may not know whom to approach. So you're absolutely right. I think it is underreported.
Great. Thank you, madam. So now let's moving on with the program. We have a special guest here from California, United States, Miss Indu Navar. She is a serial entrepreneur, has co-founded several technology companies, including a health technology, Healthion, now WebMD. And she's a force to reckon, as she has a personal connection in her family to ALS and MND. She's also on the board of Global Genes, a nonprofit foundation advocating for patients with rare diseases on a global scale. And she's been a collaborator with us. So it's my pleasure to welcome Ms. Indu. Take it.
Thank you very much. Well, thank you for having me here. And let me bring up my presentation. And like Harsha said, this is a personal journey for me. And I am focused today, Everything ALS, which is Peter Cohen Foundation, is a nonprofit organization, and we are focused on bringing in biomarkers for ALS. So when we say biomarkers, we'll go a little bit detailed. It's called digital biomarkers. And who am I? I'm a technologist, and I helped start companies, and my husband was 18 years at Amazon, and most of you actually enjoy his discovery. He was one of the co-founders of AWS, which is Amazon Cloud today. And he was 49 years old, and he had his first symptom, which was an ankle, what we call a foot drop. And we didn't think anything of it because, we ate everything organic, we exercised, we did everything by the books. And anyway, we went to Stanford very early. And what we heard was, it's so early to say what it is. Please come back after 8 months. And why 8 months? 8 months was random because nobody knew what was going on or what it could be. So as Dr. Gauri said, this is a diagnosis of elimination. So that is, we do a lot of tests to say what it is not. And we're sitting there, and most of the time we were praying that it's brain tumor or something else, right? Because at least there is something that we can do about it and not ALS. Unfortunately, after walking through, Stanford, Johns Hopkins, Mayo, and also Mass General, who were all our doctors, we got diagnosed after 2.5 years at Mayo Clinic. And that's how long it took, 2.5 years. And we were not busy. This was our number one thing. And what it told me was, it's not about getting to the doctors on time. Yes, that's a problem. It's also not having any tools to figure out what is going on. So unfortunately, my dear husband, who's the love of my life, passed away August 13, 2019. So I had two things. I could actually walk away from this, or I could say, I learned so much, I have opinions about it, so I need to double down and do something about this. So I chose to become bigger than my fears and do something about this. And I do not, my whole sole purpose is, I cannot have a suffering that came to us and our family as counted as one of the victims in the disease. I want him to be known as somebody who actually brought treatment for this disease. And that's him. And, when I set out to do this, I'm not a physician, I'm not a neurologist, but what I have is entrepreneurship. I knew these skills that I have put together through 20 years of my career. I knew speed, I knew how to do value alignment with people, and also I'm a fast learner and knew how to grow companies and manage teams. And with this experience, I set out to do Everything ALS, which is a nonprofit organization. And why is this important? In my books, neurological disorder is a growing problem. We're going to have over $1 billion, billion people with this disease, with neurological diseases by 2030. And somebody mentioned MS and ALS is very equivalent. Yes, that's kind of the prevalence that has been published by Johns Hopkins as well. But it's not only in the numbers. I mean, if you really look at the cost of this is tremendous. 2.5 years we went through the diagnosis. It takes billions of dollars to diagnose the 6,000 people in the United States with ALS. So this is a growing problem. And if you see, why is pharma companies walking away from neuroscience? Why are they walking away from neurology? And if you see the number, we're barely about ophthalmology, and this is a killing disease. That is because lack of successes in clinical trials. And when you say, why is there lack of successes? That's because we don't have a biomarker. And today, we humans are being digitized with new sensors. All of us have some kind of sensor, and we actually use it to track, analyze our behaviors. And what we want to do is bring that kind of innovative technology to ALS and also neurological diseases. And ALS has got Dr. Gowri said very, very well on some of these things. I'm not going to go deep into what ALS is, but wanted to point out it does take 12 to 18 months in the United States to diagnose, which is method of elimination, and the survival is 2 to 5 years from the time you start the symptoms. Do the math. That is, many people actually pass away before they're getting diagnosed. And it is projected to increase 34% just in the United States by 2040. And 90% of the cases are sporadic, and that means we have no idea why it's happening. And the important point is, in the last 30 years, more than 200 clinical trials have failed. And we have 2 drugs that has been approved. They extend life by a few months at most. And there's no biomarker or diagnostics. So what do we do today? We have ALS FRS score that is pen and paper. So there are 48-point scale and 12 questions in these 4 category. And we used to go to the doctors and they would ask these questions. I promise, I thought it was like an AT&T or T-Mobile survey questions. I had no idea this is our gold standard. And they would ask us questions like, how do you turn in bed? What does that even mean, right? My husband would look at me and I would say, of course you can do it, because I was nervous that he would feel sad if I said anything else. So these are the inputs we take, and then we try to actually figure out how the progression is happening. So really, in technology, we always say junk in, junk out, right? So it doesn't matter what statistics you do. And this is not just in ALS. We really, if we can actually bring this to ALS, this is very applicable for many other neurological diseases. As you can see, this is an issue across multiple neuro diseases. And we have movement, we have bulbar, which is the speech and the salivation and cognition and sleep. All of these are implicated in many of these neurological diseases. So what's the goal? So Everything ALS is focused on fostering collaboration for development of standardized biomarkers. And we want to extend the use of digital biomarkers as experimental and secondary endpoints in clinical trials. And we want to standardize it, help validate it, and bring it in front of the regulatory acceptance. And we want to bring acceleration and efficiency to clinical trials in patient selection, clinical endpoints, and not to leave earlier diagnosis. I would like us to stop from saying, come back after 8 months, which is an arbitrary thing, and we'll see how bad you are, how you're doing. Instead of that, I would have loved to have a box of sensors, so we're doing continuous physical exam. So with that in mind, we have our supporting team. We work in, everyday basis with this team. So we've partnered with Harvard University, which is MGH, the #1 neurology center in the United States, James Berry, who runs our the digital biomarker, and Ernest Frankel, who is an MIT professor, and IBM Research, and Alex Sherman, who runs the data platform. And this is a few of them. We also added Lyle Austro from Johns Hopkins recently. So this is our scientific advisors, and we work very, very closely on an everyday basis. And what we do is everything ALS research. So we are a research organization as a nonprofit, and also we're an advocacy. And what we do is we create a large, collaborative, high quality, innovative community resource, which is open innovation, open source. And our goal is to start preparing for integration of digital biomarkers into clinical trials. And how does it look? What we did was, how do you get patients, right? How do you get this data? How do we get this longitudinal data? So we created our own patient community where we have events where patients come in, patient and caregivers and the community interact in this community. And from that, we actually do what we call citizen-driven research. So we actually do the IRB approved research, which is data collection. And also we have our data science team. And also we use data use agreement with many other institutions to distribute the data so we can actually provide insight. So how does it look like in a block diagram? If you see everything ALS on the right-hand side, it's a patient-mediated data. And who owns the data? Patients own the data. We are the custodians of the data, which is consented by patients to do the right thing. That is not to lock the data, but to distribute it as widely as possible so we can actually find the needle in the haystack, as we are doing. So we work with many AI startups which have sensors, and we conduct, like I said, IRB platform. We collect the data, which is in the open mediated data, and that's used by many researchers using the agreements, and also AI community, and also pharmaceutical companies, which not only uses this data and also include these biomarkers in the preclinical and phase 1 and 2 and 3. And recently we did sign an agreement with Critical Path Institute, which is a FDA funded organization, to accelerate our discoveries. And Hogan Lovells is a very well-known attorney, law firm which focuses on bringing in these discoveries to commercialization. So our goal is not to have it as publication alone, because publication is great, on our way, but we need to commercialize these products or these findings so we can be used in clinical trials. And in average, traditional studies are slow and expensive. That is, it gets sponsored by an institution, the data gets locked, and it never gets shared. In contrast, what we do is citizen-driven research, where we get hundreds and thousands of people engaged simultaneously, and this data is distributed among many researchers simultaneously, which is very cost-effective and also much more faster. And Alex Sherman, who is at MGH, says, current institutional research model is like building one stadium for each game, and then we bring down the whole stadium, right? What we are building it's a stadium where you're playing many games at the same time. So we are bringing in many sensors. I'm going to go through the statistics very, very quickly. If you have more questions, please contact me, indo@everythingals.org. So we have a very large community. We bring in people. We have from 33 countries, 135,000 people, unique visitors come to our YouTube channel, and we have over 5,000 people who attend our live events, who actually, have not only live events, they also get to talk to each other online. It's all online. So from that, we do research. So our first research we did was speech, video, and cognition, and also search engine interaction. That is looking at Bing search engine, how we can look at fine motors and detect ALS very early. This is with Microsoft Research, and now we just kicked off with Bristol Myers Squibb's working with us on walking, breathing, and speech all together. So if you see on the right-hand side, like I said, these are all questionnaire. We've done bulbar, we're doing respiratory and gross motor, and fine motor is what we will attempt to do in the next, in Q4. And in contrast, we have collected 1,000 hours of data in just 14 months, and this was our first one. So, and we've actually enrolled, consented over 800 people, and we're doing this in the United States, but we would love to do it in India. And, so this was one of the very exciting moment for me when Harsha called me, because we would absolutely love to extend this to the population outside the United States. And we collect a lot of the data and, from video, and we're getting some exciting results. We see early results in changes in the phase and also changes in the speech when it's really not even, symptom yet. So machine learning and AI is a really good way, good use for early detection of these symptoms. And like I mentioned, we're going to do bulbar, respiratory, and fine motor. So by the end of Q1 2023, we will have all of the data from all of the 4 different regions in ALS-FRS score, and that means it's a whole body that we can actually emulate, and we have done some publications and along the way as well. So with that, I want to thank you for having me here, and look forward to doing more collaboration with many of you here.
Thank you so much, Indu, for sharing such a powerful, inspiring story. The love of a wife for her husband with ALS has the determination and perseverance tempered by science and technology. So I really see the light at the end of the tunnel with where you are going with this. It's not straight jumping to a treatment, but you have to start with that biomarker, and that's going to guide us towards more clinical trials which can be successful. Very inspiring, and thank you for sharing the story.
Thank you for having me.
So we'll move on with the program. Let me remind everyone that today is International Motor Neuron Disease Day, and we are. It's our pleasure to collaborate with the MND Trust and NIMHANS, the institutions that we are working with, as well as the support of government with Dr. Swasti Charan's presence here, and the will and determination of caregivers and family members like Indu. That's going to drive the next phase of accelerating diagnostics and treatments for ALS and MND, and also serve as an example for many other related disorders that we are seeing in the chat with the VCP and other diseases that are neuromuscular and related as well. So to move on to the next phase of the program of panel discussion, let me properly introduce myself. I have been hosting some of the program already. I'm the founder and executive chair of IndoUS Organization for Rare Diseases, one of the organizers of this event. And I'm also the founder of Jiva eClinical Software Cloud, which has several of the features that Indu was mentioning around software for remote patient engagement and data collection. I also serve on the board of Greater Gift and several other nonprofit and for-profit organizations as a disclosure. My inspiration also, like Indu and Mr. Vasant Rao, who is also inspired by and driven by his love for his wife that he lost to MND and ALS. I lost a child to a rare disease in 2012. And that's when I got determined, coming out of National Institutes of Health as a data scientist, to see the lack of diversity and Indian genetics data and the lack of Indian patient clinical data in global databases. And medicine is increasingly data driven, and without being in these scientific databases, we get left out. And that's the motivation for patient registries as well, which are essentially informational databases. So I will now start the panel program, but before introducing the speakers, just have a quick few remarks. A patient registry, formal definition is that it's a collection of standardized information about a group of individuals, such as those with a specific disease like MND and ALS, that's used for a variety of specifically defined purposes. And so registry becomes a powerful tool if it is designed properly, like Dr. Gauri Devi laid out very eloquently, and the entire best practice and how to go about it. The plan was really crystal clear. But it's very important to engage every person with the ALS and MND in this exercise, because every person matters. There is a lot of heterogeneity, and not every patient demonstrates the same symptoms. A registry can be just a contact registry with contact information of patients, but it can also be a natural history registry, which is what Dr. Gauri Devi was talking about. It contains more detailed clinical information collected over a period of time. And Indu shared a lot of such data as well. So today's theme is best practices for rare disease registry. And the most credible source that I am aware of is the National Institutes of Health, NCADS, has this program called Rare Disease Registry Program, RADAR. And it's a great resource, provides a step-by-step guide and best practices to develop a registry for any disease. And then there are disease-specific experts such as Gauri Devi and other clinicians on this panel who can guide us on the specific disease-related data and what to collect and all the other specific information. So how does this relate to the journey of a patient? Most patients remain undiagnosed and like it was presented. And then once they do get diagnosed with a rare disease, they are lucky if they are part of the 5 to 7% of patient diseases for which there is a FDA approved treatment, and if they can afford it somehow. But many times they are diagnosed with a disease without any FDA approved treatment, such as ALS or MND. And that's where the best thing that can happen to them is that they enroll in a clinical trial for a therapy that has better potential than the standard of care. And so in this entire journey, right now there are more than 2,000 clinical trials approximately registered in clinical trials databases for all rare diseases combined. And for ALS, MND in particular, over 150 clinical trials ongoing. And hence, if you look at the global map of MND and ALS patient registries, several registries have been launched since 2009, starting in Italy, and then in the US, Canada, as well as recently in New Zealand in 2017. And so it's really, we are already late to the game in India. So I think this is a great team that can figure out how we can launch a well thought out registry program in India. So that's where the Indo-US Organization for Rare Diseases comes in, is we recognize this global divide. Historically, over the last 100 years, majority of clinical trials happen in the United States and Europe predominantly, about 80%. And then the rest of the world is less engaged, as much of the funding, both private and public funding for clinical research, happens in US and Europe. So our mission is to connect patients of Indian diaspora globally with expertise and clinical research, and raise awareness about the need for data and the need for registries and other such programs. I encourage each one of you to look at our programs like the Patient Alliance membership. If you are a patient foundation, such as MND Trust, we welcome you to join our Patient Alliance membership program. If you are an individual patient, you can submit a request for support on our patient concierge on our website, and expert staff will dig up information specific to your request from NIH and other sources globally and provide informational assistance. We are not medical doctors, but we provide connections and informational assistance. We have launched a corporate alliance program with several industry members, as it requires a cross-stakeholder collaboration. So I invite any industry members to consider joining our corporate alliance program. and various other research, education, and policy advocacy efforts. So when we look at the patient registry or a study, which is a longitudinal study focused over a long period of time, we need to engage the clinical staff, researchers, and patients have to communicate by various modes of communication, email, SMS, audio, video, and for educating patients, obtaining informed consent for the data collection and screening them, enrolling them into a program, collection of data through questionnaires and surveys, as well as identifying any adverse events that may be happening from the treatments that they may be taking. So enabling all of this in a flexible manner does take several considerations. I will skip this slide because I think Dr. Gauri Devi very nicely covered most of these considerations. But I'll just highlight a couple very important things, which is the intended uses and purpose of the registry is extremely important. And based on that, the regulatory and the ethical guidelines that apply or do not apply can be sorted out. And only when registries are started with that purpose well defined, the ownership and stewardship of that patient data can also be defined, whether it's organizational, individual patient consent, but also how the data can be shared as an aggregate, and so on. Can be developed. And it's also important to start off with building the registry on the right kind of software or a tool and database that has the flexibility and the ability to capture the type of data that's necessary for the intended purposes. So one software that I have been as a data scientist looking at where what are the key barriers and bottlenecks in any longitudinal cohort study, whether registry or a clinical trial or otherwise, is ability to identify, screen, and enroll patients remotely on an online platform, rather than having them to physically go into a clinic or site every single time. It cannot be avoided. It has to happen in-person visits also wherever necessary, but where it can be avoided, that will help with telemedicine, remote engagement, communication on a single integrated app. So that's, and it needs to be compliant with the data security, privacy, and those standards as provided by appropriate regulators as well. So with that background, let's start off the panel discussion. And I request all attendees to drop in the chat window, what is your hope for ALS and MND patients? And that we will look at towards the end of this program. And to start introducing our speakers, I request and call upon each speaker to introduce themselves and share us about their personal experience and perspectives as it relates to patient registry and ALS or MND. So starting with Dr. Nalini, going by alphabetical order. Welcome, Dr. Nalini, please introduce yourself.
Yeah, thank you for this wonderful program, and thank you, Dr. Harsha and Mr. Vasant Rao and Ms. Indunawar for this fantastic initiative. And I'm Dr. Nalini, Professor of Neurology. My mentor has been Professor Gauri Devi way back. I joined in 1989 at NIMHANS, and for the last 32 years, I've been working on neuromuscular disorders with special interest in motor neuron disease. And we at NIMHANS started a motor neuron registry, disease registry way back in the 1990s early, along with Madam Gauri Devi, and from 1976, if I'm correct, was the first case registered at NIMHANS. And since then, we have more than 5,000 cases of clinically diagnosed motor neuron disease, and we have a hospital-based registry. Like most of the cases are entered into the database, into the particularly the clinical data, the onset, the duration. And we did compile all of this data in late 2000 and published in 2008 on more than 1,000 cases of motor neuron disease, which were seen over 35 years prior to that. And we also tried doing a survival pattern So it was not exactly, I would say, natural history. It is possibly a disease progression. So we got about more than 125 patients who had succumbed to motor neuron disease and looked at their survival pattern. And we found that Indian patients do survive for a very long time. The bulbar onset almost lived for more than close to 5 years. And the limb onset had a mean of around 8 or 8.4 years, if I'm correct. So we're not sure how come the Indian patients live so long after a clinical diagnosis has been made. I just yesterday in my outpatient, I saw 11 patients of motor neuron disease, and it varied from age of around 39 years to as late as 72 years. So every Monday, we see about 9 to 10 cases of clinically definite ALS referred from various institutes in the country and various neurologists who do make a diagnosis of motor neuron disease. They do write it in their prescriptions and their clinical notes, but on many occasions, the disease is not, the breaking the news is not being done by them. So they just do send to institutes where we do see more cases, and possibly we need to give the verdict that the patient is suffering from motor neuron disease. So that's a little sad, but on most occasions, when patients come to NIMHANS and seen by physicians or by neurologists, the diagnosis is quite clearly written in the slips. But only thing, the time taken for them to reach institutes like us, it's not very late. I think the time to diagnosis in India is just a few months. I see patients as early as 1 month, as early as 2 months with just change in voice, or just a few fasciculations, or just a little bit of wasting of the small muscles of the hand. So because they can reach us, I mean, there is no hierarchical system here in India, and anybody can just walk into our outpatient and see the specialist by just paying ₹20 and get themselves registered and say that I want to see a specialist at NIMHANS or any AIMS or Sri Chitra. So the diagnostic delay, I think, is not as much as what is being projected from other countries, because once a GP sees, and it takes several months, sometimes a year, for them to see the specialist. So in that way, our experience. So for registry, we have been thinking almost for the last 20 years that we should have a natural motor neuron disease registry. Madam Gauri Devi had made an initiative. We did have some talks with ICMR. Madam also had. But the current rare disorders registry does not include ALS, because as Madam Rita Raseli told, they would like to have inclusion of diseases which possibly have or a proposed therapy available for these patients with genetically mediated disorders most of the time. Great. So ALS currently does not have a specific treatment, so it's not been included in the list of diseases in the rare disorders registry.
Yes, thank you, Madam.
For me, I think a national registry would be very, very important. And let's all make efforts. We have a hospital registry, but that could be translated into a national registry, and all of this data could be put onto the national registry.
Thank you so much for those introductory comments. We'll move on to the next speaker. We will have a number of questions for each one of you after the introductory remarks. Thank you. Dr. Mohammad Farooq, kindly introduce yourself.
Yeah, hello all. Good evening. Myself, Farooq. I work at CSR Institute of Genomics and Integrative Biology, and it's been 15 years of mine in this institute. And I did my MBBS, and rather than following a typical course of medical graduate, I followed a path of research, got into PhD program at AIMS, and was working with another similar neurodegenerative disorder, but next in prevalence, in terms of commonality. After ALS, it is spinocerebellar ataxias. So I've been working with AIMS and for these many years, and we have around, like again, as Dr. Nalini was mentioning about MND registry, we're deeply working with spinocerebellar ataxias. And with the learning from the genetics of spinocerebellar ataxias, we started just 5-6 years ago the similar things to be done for other neurogenetic disorders. And I've worked with Dr. Nalini and other prominent neurologists in the area of motor neuron disease and muscular dystrophies and even Parkinson disorder. So overall, we are running a pan-India program here just for equitable access for genomic medicine. Sometimes a patient all cannot afford the diagnostic cost. So somehow we are into kind of a service that we can provide some testing of common mutations for various genetic disorders. And we have so far catered to more than 10,000 patients in 5-6 years. And we have around 300 different genetic disorder testing facility available at our place. And this way, like say, I come across in connect with MND patients also, and I have a lot of inspiration from patients themselves to work continuously for this. And with that, I'd like to thank Harsha and all the people who has invited me. Thank you so much.
Thank you for. Now I welcome Dr. Shruti Nair to introduce yourself.
Very good evening. Thank you very much for having me here. It was a great privilege listening to Professor Gauri Devi Madam, Dr. Swasti Charan and Ms. Indu Nawar. It was great talks from all of them. I'm Dr. Shruti S. Nair. I'm an Associate Professor of Neurology in Sridhar Tirunal Institute for Medical Science and Technology. We are located in Trivandrum, India. We are a tertiary care center for neurological and cardiac disorders. We have a specialized neuromuscular department in our center, and we cater to approximately 75 to 80 patients, new patients with ALS every year. We have a specific MND clinic, and as per the way it runs currently, we have around 5 to 7 patients with MND coming to a clinic every week. Unfortunately, as we know, there is a lot of attrition and lot of data lost follow-up. What we have conducted in terms of understanding the diseases, we have done retrospective analysis of our data. We don't have a prospective registry. So it's based on this for the last 10 years that I've come up with these numbers. What we are specifically doing in research in motor neuron diseases, we are trying to understand a few biomarkers, particularly looking into electrical biomarkers such as motor unit number index, and specific measures to understand the disease progression in MND versus other motor neuron disorders like Shyama disease. And we are also looking into the atypical and non-motor manifestations in ALS as a research program. It is high time, I agree with everyone that it's a high time that we have had a natural history cohort and be trial ready for a new ALS treatments. Thank you.
Thank you so much, Shruti, for the introduction. Now I invite Dr. Rita Roseli to introduce yourself. Hi, Rita.
Hello.
Yes.
Good evening to one and all. I thank the organizers for inviting me to this important webinar, and especially to take part in this panel discussion. I'm not a neurologist. I'm a pediatrician by training. I worked at Indian Council of Medical Research. I'm basically a research administrator. I was heading the division of reproductive biology, maternal and child health. And I bring with me experience of conducting, coordinating, and designing and implementing many task force studies, including the registry. And I was a key person, I will say, to initiate this rare disease registry at Indian Council of Medical Research. And I, in fact, I bring in with me the experience of establishing a rare disease registry. I hope I'll be able to contribute to this extent, to some extent, how to establish a registry. So whatever questions are there for me, I'll be happy to answer them.
Thank you, Rita. Your leadership in setting up the National Registry for Rare Diseases in India at ICMR is commendable, and your expertise would be very much sought for as we consider launching registries for various other rare diseases. So thank you for joining us here.
Thank you so much.
Now I invite Ms. Charlene Son-Rigby to introduce yourself.
Hi, good evening. Thank you for inviting me to participate in this excellent event. Wonderful talk so far. I really learned a lot today. I'm Charlene Son-Rigby, and I'm the CEO of RareX. We have developed a platform that enables patient communities to gather, structure, and share patient level data, really with a focus on accelerating research and driving toward cures for rare diseases. And we're really doing this across the thousands of rare diseases that exist. In terms of my background, I have spent the last 20 years building software solutions for analysis of big data. So both in the healthcare space as well as in the enterprise data space. And prior to joining RareX, I was the chief business officer of Fabric Genomics, where we were building artificial intelligence solutions to speed diagnosis of patients, rare disease patients, through genomics. And in terms of my why, I am also the mother to an 8-year-old girl, Juno, who has a rare neurodevelopmental disorder. And so in 2017, I co-founded the STXBP1 Foundation to advance development of meaningful therapies for kids like my daughter. So at RareX, what we're doing is we are applying our collective team's learnings on registries and data collection to deliver this robust cross-disorder data collection platform. We launched in the US last year, and there are now over 30 diseases that are collecting data on our platform, and over 70% of those are neurological. So we're now collaborating with IndoUSrare on a pilot for Indian patients, which is launching this summer, and I'm very excited about that. And I wanted to comment that one of the things that I'm really taking away from this session today is the momentum that's building in India around rare disease, the centers of excellence, and data collection. So thank you for including me in this discussion.
It's fantastic to have you, Charlene. Thank you for that introduction. So I want to also inform everybody that we collaborated with RareX on a grant that we received to study the feasibility of patient-reported outcomes in India in 2020 and 2021. It's a full report published that I invite everyone to access and download from our website. But the key takeaways from that several literature surveys and 35 stakeholder interviews that included patients, physicians, and other stakeholders is that there is a lot of strengths around novelty and uniqueness of the concept of engaging patients directly on a digital platform online for data collection, and the cohesiveness with the new digital health mission in India that's now setting a great momentum and resources for digital health. But also there is also great interest in participating in any such programs as we launch, as well as successful registry programs for HIV and other common indications where motivating to do similar work in rare diseases as well. So there are significant weaknesses and threats as well that we need to be aware of, but the strengths and opportunities far outweigh these weaknesses. And I think with the kind of collaborations that we are seeing on this webinar, we should be able to overcome those weaknesses and threats to really accelerate these programs forward. So thank you, Charlene, and your collaboration. As we move on, as you're on the screen, I request all panel speakers to now turn on your videos so we can get through a series of rapid fire questions. And I request each one of you to make your responses in 60 seconds and with opportunity for follow-on conversation as well, as we have maybe 15 questions to go at it. So Charlene, starting with you, why would you say a patient with MND and ALS care about a patient registry? Given the delays in diagnosis and the survival rates, why should a patient care?
So I think that you captured it very well in one of your slides, saying that every patient matters. So in ALS and generally in neuro disorders, there is a spectrum of symptoms. And so it's very important for us to be able to capture that spectrum of symptoms for each patient, to be able to contribute to our overall understanding of the disease and to accelerate therapies, which is so important to our patients.
Thank you for that. Anyone else has an opinion on that question?
If I can come in here.
Yes, please.
Every patient of ALS wants to know what is going to happen in progression. So if they are a part of the registry, we can then inform the patient, listen, like you, there have been another 100 or plus patients, and this is how they behaved. Once the diagnosis is made, that's the next question they ask. How long will I live? Or the caregiver says, what is the expected time? Because they want to plan their activities. So to that point, we can mention that you being a part of registry will not only help you and your family, but others also in the country. That's how I look at the patient's role, individual patient's role in the registry.
Yeah, very well said. Indu, Vasant, do you have a perspective, having been a caregiver? How would you rationalize a patient and caregiver's time to contribute towards a registry? You are on mute, Vasant.
See, I share the same experience that Indu had in the early diagnosis of the disease, which I think in my case also took more than 2.5 years. And as they rightly put it, there was no biomarker for me to decide whether she was having, it was through a process of elimination that I finally decided after 2.5 years that she was diagnosed as ALS. I think this registry is a very important aspect of this particular discussion, because we do not know how many people suffer from this particular disease, and to bring it to a point wherein we sensitize the government to include MND also into a rare disease category, and they to get the same kind of financial benefits that they're getting in, and has been affecting a very large section of population who cannot afford this treatment. In fact, I've had a couple of people with me last week who just could not afford the ordinary treatment that were there. So I'm referring them to NIMHANS, but everywhere there is a stumbling block. They need a place to stay and things like this. So I think we need to sensitize the government, and to do this particular thing, I think we need to have a registry. One. Secondly, I think there must be some kind of an insurance coverage for people with MND and other rare diseases as well. This is my brief suggestion that I have at this point in time.
Thank you. Noted, Vasant. Very important. Moving on to the next question. Why should a neurologist treating MND ALS patients care about patient registry? And how can a patient registry actually help in drug discovery, research, and development? I think this was already touched upon in the presentations, but anything more that the neurologists in the panel like to add? Nalini, do you have any additional thoughts on this?
No. See, the registry itself is, we know it's very essential. And in the registry, we have components of the onset, the duration, and even maybe the end of life care and end of life events, and time to diagnosis, time to death. So this will help us. Obviously, whatever drug is going to be discovered is the efficacy of the drug will be known only when we know whether it alters the course of the disease. So whether, if it's not going to completely improve or completely the patient is going to recover from the illness, at least the alteration would be known only when we know a natural history curve. And from the registry, we can have at least some components of disease progression. So rapidly progressive, slowly progressive one. What are the factors, predisposing factors, which may lead to the course of the illness? So I think a registry with enough and more data about the evolution of the disease will help us, so that we need to have drugs which are going to either alter the progression or stop the progression or have a recovery of the symptoms. So I think a registry is a must.
Great.
And I think in a national, different ethnicities like East, West, North, South have different patterns also within India, we have seen. So even that would be become more prominent or aware of these sort of differences based on ethnicity or the location or geographical region from where the patients are coming. I think that would be very important.
Great points. Shruti, you have your hand raised.
Yeah, thank you. I agree with Nalini Madam that this is the most important part of being trial ready, because we are right now in an area where we are booming, there are new therapies coming up, and unless we have a collective information regarding all these different types of MND, including the genetic data, we will not be able to implement any of these clinical trials in a meaningful manner. Because these are rare diseases, it is very difficult to get a homogeneous population to start off the studies. And as again shown by the NIMHANS study, the MND in India is not the same as the MND we see elsewhere. So we need to have a data on our patients, and the same trend is also reflected in the data we see from our side. I think it's very important to have our own registry, our own group of patients who can, be ready for a trial as and when the therapy becomes available.
Thank you. Farooq?
May I make one comment which Mr. Vasantrao mentioned?
Sure.
See, drugs is one aspect, but what patients are asking is other supportive therapy, like, ventilatory dysfunction, they have to have a BiPAP. If they have difficulty in swallowing, PEG has to be done, so there are many issues which the government can help, because cost of the equipment and even the head drop, nice inventions are occurring, how to keep the neck straight, mobility improvement, transfer of the person. You see, these are, we are waiting for the miracle drug, so-called, within inverted commas, but we don't know when it comes. But till then, how do we handle our patients? That is where I think the government can support. Many patients have asked me, I can't afford this. Is there any help? So I think this MND Trust, apart from clinical trials and whatever we are talking, also has to influence the government, firstly to include on the rare disease list, and clearly mention that there are no specific drug at the present. Therefore, a lot of supportive treatment is required. And I don't know why 2.5 years delay is happening. I agree with Nalini. Patients just walk straight into Gangaram Hospital, and we have diagnosed as early as 3 months. 2 months, they say, yes, I noticed this. And, they came for an examination in neurological assessment. In India's system, gate crashing is very easy, unlike other countries where you have to go through the general practitioner, physician, neurologist, referrals. It takes 8 months to 1 year, I've been told.
Yeah.
Here it is like, today they ring up and say, can we come and see you tomorrow? Fine.
Yeah. Right.
That's it. So while we have a lot of disadvantages in our health system, this is one thing we should not lose.
That's very true.
And I entirely agree with Nalini. My experience is the same. Of course, unfortunate are those patients who are remote in small towns, in some remote areas. They find difficulty in reaching. But most of the cities, tier 1, tier 2 and metros, people seem to come.
Yeah.
I'm sure the Trivandrum experience is the same, right?
Yes. Farooq, you have a comment?
We can look at the positive aspects of our patients also, not always the negative.
Certainly.
Yeah, Harsha, thanks. I just wanted to add here from the first question, for the first question you said from patient point of view. I think when I hear like some stories from my own experience with ataxia patients, and even lately with MND and other neurodegenerative disorder patients, I think what is important here is that, like in India, you can realize very well that we are lagging a lot, actually. Not even by like representing our patient in a part of like international forum in a way that like to make them part of science and just to feel them they are connected with the world or global efforts. So I think the prime responsibility of us, I think, resides in then connecting each and every patient to these international efforts and make them feel not so neglected, like say when they are diagnosed here in Indian setting. So then they have a lot of questions. Why do not we have treatment for this disease? What options we have? And a lot of the things clinical fraternity has already mentioned. So I think that's very important from patient perspective that I think we have, suppose if you have action plan for a patient whenever, as soon as he has been diagnosed with a genetic ALS or non-genetic ALS. So I think in that perspective, I think it's a great support. It would come through registry system. That's what is the point I just wanted to make. Thanks.
Great point. Thank you. So let's move on to the next topic of discussion, which is what are the key considerations while designing a patient registry in general for any disease? And then we will talk about the specific aspects for ALS and MND. I think Dr. Gauri mentioned several of them in her presentation. Charlene, go ahead, please.
Great, thank you. Sorry, my hand raise is on my flower, I realize. It's hard to see. So one first principle that I think is really important that I want to put forward is that registries need to enable maximal use of the data that patients have contributed. And I think this is very true for ALS, but I think this is really imperative across rare diseases. And data also needs to be patient owned. Patients are contributing their data, and we need to recognize this contribution as really the patient owners. And I've been really excited that I've heard this theme across the speakers today. I strongly agreed with Dr. Guri's point that data sharing needs to be simple, because it's already complicated for the patients as well as the researchers. We really need to simplify. And so one of the things that we've done at RareX is we've developed a patient-focused approach to data governance. It's modeled on GA4GH, but with the added patient view. And so patients can decide how they want to share their data. And then it also, on the back end, enables the data to be openly and responsibly shared for research. One of the challenges that we have, and I think we've only talked about it a little today, is that traditional research and registries have often led to siloed data. And so then that data is only held within one research study or within a single center. And some of that has to do with alignment of incentives, but the other is that oftentimes the consent did not allow for sharing. And so we really need to change that so that we are able to do the right thing in terms of sharing that precious data that's been contributed. I know I'm running a little long, but just a couple more things I wanted to talk about were data standards. So in terms of designing a registry, standards are very important. And so, at RareX, we've invested a lot of time identifying existing assessments that can be used cross disorder using an expert multi-stakeholder working group approach. And finally, mapping to data standards. So human phenotype ontology, SNOMED, ICD-10, this will make the data research ready and also enable it to be aggregated. And then one point that has been brought up, and I also saw it in the chat around remote and mobile. So I think this is a really important point. There's clearly data that's going to be collected in clinic, and that is an important set of data. But collecting data that's patient reported and being able to enable this remotely is critical, especially as you have patients who are not in cities, and this enables that ongoing data collection and participation.
Thank you. Those are all very insightful comments. Thank you, Charlene. Rita, you have a lot of experience in the Indian context. If you can share yours, please, and you're on.
Yeah, so we have known what is the patient registry and the benefit of having a patient registry. So, when we, I think it is important. There are so many things we want to learn from the registry, but it is important to define, right, the purpose of the registry. So we may be interested in 100 of things, but is it possible to do everything under the registry? So we have to be very specific, and we need to define, right? And also we should be, I think, keep on mind the outcome that we are interested in. That's very important point, so that we don't lose focus, right? And also having identifying a proper study design, that is also important. At the end, most of the registries are analytic design, so be mostly observational, right? And also I think identification of centers, and also identifying professionals, physicians who are interested. We must have that infrastructure where we are able to provide, because in the registry, we are including patients only after the diagnosis is confirmed, right? And also, the center must have a patient pool also. So how do you identify all such centers? Do we have a network of physicians who will provide you that kind of information? So that is also important for, right? And also a patient recruitment, how will you recruit the patient, right? and also developing the data collection tools, right? Which includes case record form, then developing data dictionary, then what is that called? Data validation tools, right? Data management tools. So many things are important. We don't pay so much attention, but at the end of the day, what we are looking at quality data, because based on that, we are looking at very important outcomes from the registry. So these are very important. So there are other things which has already been shared, like, the software tool has to be developed, and the data entry program has to be developed. We have to identify people who will enter the data. How is it the physician, or do we need some support team for entering the data? And then when we have multiple centers involved, it's not that everybody is busy in their clinical practice. We need some resources. What kind of resources? We need to have planning. And then how long we are going to sustain? Are we looking at some funding source? So from our own registry, from at ICMR, what we have developed, it's a national registry. We also had challenges. We thought, see, in India, I think there are only a few centers where we have the expertise to do molecular diagnosis or genetic studies. So although we invited letter of intent from we had the call for letter of intent, although more than 100 applications were received, but when we finally looked at the infrastructure that are available at the centers and the patient pool, in fact, they were very, not many, it was less than 50%. And then we asked for more details, then finally we got only 22 centers participating in the registry. So, we talk about the registry, but whom are we going to involve? So this is the status in the tertiary level hospitals, and tertiary level hospitals do not reflect all the patient pool. We have 70% of the population living in the community. So in our national registry, we have 6 major group of disorders, although we have NMD, but then, we could not include motor neuron disease and ALS because our criteria was, the diseases that were included, they must be amenable to treatment, or there should be some treatment available. Because the point is, when the patients are coming, you are taking consent from them, they will be expecting something from you.
Yes.
Right?
Yes.
So that is one, I think, very humanistic point of view that one has to keep in mind. So in the first phase, we have only limited to this group of disorders. And maybe in the second phase, we will be trying to see, work out whether how we can include more diseases and confirmation of diagnosis for MND and ALS. So ALS, as rightly has been pointed out by all, there is no biomarker. So it's based on clinical diagnosis. So what we take as confirmatory diagnosis, I think these are certain things that should be further discussed, further research, further consultation on these things are required. So and then where we talk about the patient, every hospital may be having, if they are not part of the national registry, then again ownership of the data comes, which we have discussed.
Yes.
Dr. Gauri Devi has
Yes.
also mentioned.
Yes, thank
Those
you.
things has to be taken into consideration.
Great. Thank you so much for
Yeah.
those comments. We are last 5 minutes of the program, and I have a few more questions to go through. So I'll ask Farooq and Shruti to comment on what do we know about the role of genetics and genome sequencing in ALS, and also any basic science, scientific discoveries recently that are exciting in this space.
I would like to say that the role of genetics has been started to be increasing for ALS, and until 2010, I think they were it was considered around 5% of MND was considered as genetic, and almost 5% was explained by almost 7 or 8 genes. And it changed quite a bit after 2011 or so with the identification of C9orf72, another gene defect. And now together, all of the 33 or almost like 40 odd genes explain around 10 to 12% of genetics of ALS. So I think maybe as we study from our clinical fraternity, they talk about risk factors, they talk about the ethnicity, they talk about the geography. So I think, and there is a heritability factor also, twin studies suggest. So I think there is, I see that there is a lot of scope for exploring genetic marker in ALS. Maybe the kind of genetic defect which we are well trained to look for are not the one implicated generally maybe involved in MND. Maybe the another maybe new ways of genetic defect might be the underlying mechanism for ALS. And as of now, like for a confirmatory one, there are 6-7 core genes which can explain almost like 7 to 8% part of genetic cohort, like say cohort of MND patients. So I think there is a lot of involvement, and genome sequencing has definitely added in the knowledge of new finding. There was KIF5A gene was the contribution from one big cohort studies of US. So I think these big cohort studies, genome sequencing and all will add up in more knowledge about genetic mechanism, and that will give us an important insight into the mechanistic understanding of sporadic ALS. So we unless we understand, unless we navigate through those paths, we'll not be able to understand the so-called assumed, I would say apparent sporadic. I would like to use that term. So they are, maybe today we see them as sporadic, but tomorrow we might be coming out with some molecular mechanism. So maybe to understand that part, this is very important.
Right. Thank you. Shruti.
Okay, I fully agree with Dr. Farooq on that. But we have understood a lot from Parkinsonism and Alzheimer's disease regarding the pathophysiology of disease from primarily the genetic studies. This is my main hope for genetic studies in ALS, to understand what triggers of the disease and where exactly we need to target in order to cure the disease. Of course, as a clinician, we also have found out patients who have specific mutations where we may have focused disease therapies. Like for BCP mutations, there are new groups who are coming up who are doing studies on the specific genetic factors and probably a cure for BCP. There is also on SOD1 mutation. So there are specific genetic therapies, but primarily genetics is a key to understanding what the disease is all about.
Thank you. So I think we are up on time almost. So I'm going to request each of the speaker to make your closing remarks and consider including any comment about promising upcoming clinical trials for MND, or what's the best thing that can happen to a patient newly diagnosed with ALS today? What's the best thing that can happen? And if you can include that in your closing statement in 30 seconds, that would be fantastic. Thank you. Let's start with Shirley. You're on mute.
Great. Can you hear me now?
Yes.
Wonderful. Well, I would say in terms of a magic wand, and I would say that it would be fantastic if we could accelerate therapies, specifically for worldwide, but also specifically for the Indian population. And if it is possible to get every ALS patient, every MND patient into a registry, that would be what I would want with a magic wand.
Thank you. Nalini?
Yeah, for me, I think that, obviously anybody would have a miraculous, want a miraculous cure for any disease like this. But if not a cure, at least if we can slow down the progression, halt it, so early diagnosis would be so crucial so that we can halt the progression. And if we know the pathophysiological process. So I think a magic wand for that at least would be very nice.
Yeah, Shruti?
So something I'm interested in is, can we look at the end point of the disease? Can we produce regeneration rather than, even if we don't understand the pathophysiology, is there anything to regenerate the neurons, even if they have died out? And something interesting which has come up in Srijitra in the biomedical technology is something they call as a human on a chip, where they're trying to accelerate the drug development process by using in vitro organ systems. So that's something we can look forward to.
Interesting. Farooq?
Yeah, I would just like to say I don't know whether magic wand will help, but I see that correctly if a right approach if we take, I think from Indian perspective, if I talk like proper participation of patient, the federal agencies, the researchers, and everything of that sort will definitely help accelerating all the like identification of therapies and making patient leaders actually. So I think if I've given a point, I would try to give that opportunity to patients, and I think more we explore, better it is, and sooner is the better, I think.
Thank you. Rita?
Yeah, I know everybody will talk about the medicine, but I would just urge that if the neurologists come together and develop a simple set of algorithms so that these patients can be picked up at the earliest from all levels. So that once the patients are brought to a proper neurologist, and anything can be possible, whether it is rehabilitative therapy or if there is a drug, definitely they will be benefited from the drug.
Thank you. Gauri ma'am?
I would think the magic wand, we all look for it, but important thing is as early as possible to make a diagnosis, because by the time the patient develops symptoms, about 20 to 30% of neurons are already, damaged. So how can you pick up the individual before this has happened? That's the challenge now. Yeah. And as early the diagnosis is made, the better it is, even if you want to intervene. And Farooq, I would say there are now recommendations that all ALS patients should undergo genetic tests, so that you pick up few people whom you didn't suspect as having a, genetic disorder, genetic abnormality, but they were considered as sporadic. And then if you can have a targeted therapy later on, one particular genetic defect, have a particular drug, as it has happened in SMA and so on. Would you agree that all patients should be tested? Because they keep asking me, Madam, should I get genetic tests done? And the general publications usually are saying, yes, we should do, if it's possible, of course. Money, the facilities, expertise being there. What is your view on that? Because that will be like a magic wand, I mean, you identify the genetic defect, you wait for a target treatment to come and, attack that area, that zone rather.
I think the pragmatic approach would be like, say, to adopt a tier 1 test strategy. Tier 1 meaning, like say the common one, at least, which are well-known causes of ALS, that if we can develop a cost-effective assay for Indian setting, meaning every patient of India cannot afford genome sequencing. Even on research basis, it will require a lot of money to be funded by ICMR or agency like those. So I think with the whatever growing knowledge coming from international or even whatever research we are doing, so I think every patient, if they can be subjected for some tier 1 testing, like say outside they have neurochip and things like that. So if we have a sort of a modality to screen common mutation, I think that at least we can offer. So at least quickly, there are low hanging fruits. So if they can be caught early, and we can decide upon the future course or prognostication, and with the time to come, we'll be able to evolve it better.
Great point.
So,
Dr.
some minimum testing at the first stage, right?
Yes,
yeah?
Yes.
Yeah. Oh,
yeah.
Good.
Thank you. I think we are upon time. I'll just request Dr. BSS Rao. Yeah.
Dr. Arshak, a couple of points. So thank you very much for the panel discussion. It was truly educative. And what I noticed and what is my observation is that the neurologist will become a key component for the initial phase of assessment and subsequently follow up, and also having a comprehensive understanding of the disease process and also the progression that translates into the registry. Most importantly, either it's a genetic analysis or various kind of biological tools which we are going to use in evaluating the biological or the various biomarkers. Each one of them comes with various clinical components which the neurologist registers in the case register. So that way, we need to have a comprehensive approach. One is the neurologist is the key component. A specific and detailed analysis of the patient, as Professor Gauri Devi Madam mentioned. What is key component is that as early as possible, if you could identify what is the cause and also identify the ALS, that will be the key component where the registry becomes a key component in the overall assessment of the disease, prognosis, treatment, therapies, and also where we could impress upon the government and the insurance policies to have a comprehensive approach for our ALS patients. I'm very sure that the discussion what we had, each one of them, whether it can be compiled in the form of some kind of a recommendations, which Professor Gauri Devi, she has been leading this entire motor neuron disease stuff, and she has a lot of the good connections in the ICMR as well, where she can influence in terms of including the ALS in the rare diseases with the ICMR. And also subsequently, networking is extremely important. These issues were also discussed during the panel discussion, identifying the teams, like-minded people, where there is an expertise and where they have the number of patients who are there in the northeast and west and south. We have a comprehensive approach and also collating all that information, evolving a national registry of ALS. That is that's what is expected in following these discussions. I am very sure that all our learned panelists will help us to do this activity. Thank you very much.
Thank you for that. I'll make one final comment before handing over for closing remarks to Dr. Venkatesh, which is my magic wand wish is that all clinical trials for ALS and MND should have a site in India. And we have eminent principal investigators right here on the screen, several of them, including Dr. Gauri Devi and Dr. Nalini, who can be investigators on these trials. And we have no reason why these clinical trials with novel interventions cannot be made available and accessible to patients in India as well, and for Indian diaspora anywhere in the world. So that would be my wish on this International MND Day. With that, I'll now invite the lead man of India for concluding remarks.
Mr. Harsha,
yes.
Can I just jump in one moment, please?
Yes, please go ahead.
Yeah, there's one Dr. Venkatramana who's trying to reach out to us.
Okay.
And we'll just give him 30 seconds to say what he wanted to say.
Okay.
Can we allow him?
Yes, go ahead.
Yeah, Mr. Venkatramana, if you're there, please. You have 30 seconds, Mr. Venkatramana. Can you hear me? Dr. Venkatramana? Hello, Dr. Venkatramana, are you there? Well, I think we have lost him in the conversation. Dr. Venkatesh, please go along and with the concluding remarks, please. And
thank you, Dr. Vasan. There is no need to project me on the screen.
Yeah.
I will share with you my concluding remarks. This 153-year-old disorder, neurological disorder, first it was detected in 1869. Today on the World MND ALS Day, experts from all over the world have gathered here to find out how best we can help the patient and their family members. It is not just the patient, and also their family members. They are under greater agony. Now, National Registry, which Dr. Gauri Devi, Dr. Nalini started thinking and bringing out 20 years ago, and now will become a very powerful tool. Thanks for each one of you for sharing your views, right from basic science to advanced treatment. And there may not be a cure, but it is treatable. It is may not be curable as on now, but it is treatable as on now. At least we can make them a little more comfortable. The National Registry will become a very powerful tool to multidisciplinary approach to find that magic miracle to happen, as Gauri Devi and Nalini you have been mentioning. Definitely it will happen. How to get it done? Can we bring out, Harsha, a white paper of what happened today with 10, 12 highlights? Can we share it with the governments where they do not have a national registry? Can we? It can happen. I will tell you, in the capacity of the principal advisor to Quality Council of India, I tell you, I will take that responsibility of taking this white paper to the concerned people through Quality Council of India. Dr. Girdhar Gyani is there. Today he could not attend. He is in US. Dr. Gauri Devi is there. These stalwarts, when their name is there in that white paper, with the support from IndoUSrare, I'm sure our representatives, authorities in our regulatory and these bodies will definitely accept it. I think my recommendation as the concluding remark, please come out with a white paper highlighting what are the why we need this national registry, how it is going to help multi-stakeholders to look at. We are all now looking at like 6 blind people trying to describe elephant. If we can be unfolded, I think all of us together, as Farooq rightly mentioned, the gene sequencing, looking at the details of the molecular level. Definitely, I am confident in my lifetime, I will see that there's a solution to this. Please make a white paper, Harsha.
We will definitely do this.
And then pass it on
Yeah.
to MND Trust. We will take it through Quality Council of India under the guidance of Gauri Devi and Dr. Girdhar Gyani, who is in US right now. And we will put in all our efforts. We'll move the mountains and see that the concerned regulatory, legislative authorities understand. And without the support of the government, we cannot move further for any national registry. And we have to ensure confidentiality of our data at the government level. Then it will happen. I wish all of you all the best. Wonderful meeting. I tell you, right from Vasant Rao to Shankar Narayan to, I tell you, the last speaker, he was trying to get our neurosurgeon, Dr. Venkatramana. And more than 100 plus, people were listening to all of us. Let us make the life of MND patients and their family members. We don't know. We may get somebody in our family also one day. We may become the victim also. Their life a little more comfortable. Thank you very much.
Thank you, Dr. Venkatesh. On that note, we will conclude this. Thank you all for staying a little longer to conclude this properly. We will come back with the white paper and share with everyone who wants. Thank you.
Thank you. Thank you so much.
Thank you, Harsha. Thank you, everyone, for this particular wonderful session that we have had. Thank you very much.
Thank you, MND Trust, with all this passion and enthusiasm. I'm sure we will reach our goal. I hope so soon. Thank you. Thank you.
Thank you very much, madam.
Thank you so much.
Everyone.
Thank you, Nisha, Ramya, Nara, Reena, for all your support in the back end, making this event a success.